present my favorite approach, that is lateral parapatellar approach for rigid valgus knees. So first, we classify the valgus knees in 3 grades. Grade 1, that is less than 10 degree valgus with normal MCL, normal and functional MCL. Grade 2nd, that is 10 to 20 degree of valgus with elongated MCL but functional. In grade 3, that is deformity is greater than 20 degree with incompetent MCL. So what are the indications of a lateral approach? Lateral unicompartmental replacement, fixed valgus knee deformity with patellar subluxation, grossly unstable knee with enlarged suprapatellar pouch, partially correctable valgus with patellar subluxation, and previous lateral incision with multiple knee operations and risk of skin undermining. So there are some advantages and disadvantages of lateral parapatellar approach. The first advantage is that this is useful for fixed valgus deformities, preserve blood supply of the patella. It prevents lateral patellar subluxation, and we can directly assess to the lateral side in valgus knee, which cannot possible with the medial approach. But it is technically demanding and may require tibial tuber osteotomy. There are some references who shows that the lateral approach with TTO is much beneficial for the rigid valgus knees by Bin Wang et al. And the Tan P et al. So this is surgical approach, I will show you. So incision, it follows superiorly at a Q angle, then it's just slightly lateral to the lateral patellar border and the lateral patellar tendon. Second, the most important that you have to incise the deeper incision in 2 different levels. The first level is just 1 to 2 centimeter lateral in the lateral laterocolumn, and the second incision is just lateral to the lateral patellar border in the synovial layer. So it will help you in future closure, as when you correct the rigid valgus deformity, it may be difficult to close the arthrotomy laterally completely. So it will help you in for the coronal jetplasty in closure. So you can see the dissection of the lateral laterocolumn to the rim, exposing the underlying synovial layer, and the second incision is just lateral to the lateral patellar border in the patella in the lateral rim. Then incise the fat pad. Do not excise the fat pad because it will help you in further closure after this surgery. Then there is an incision of the anterior Gardner's tubercle to elevate to raise the ITV insertion. So you can see the patella is dislocated over the medial condyle. Now you can raise the lateral soft tissue structures from lateral capsular insertion along the lateral tibial plateau. Then release the lateral capsule, periosteum, elevated from the lateral femoral condyle. And this is the closure trick that closure is done in flexion starting distally with fat pad and lateral meniscus which you left that time, and then you close the lateral laterocolumn superior layer with the deeper capsular synovial layer. That is coronal jetplasty, which help you in the closure at the end. So you can see the watertight closure after the surgery, and these are my pre-op X-rays and post-op X-rays after surgery. Thank you.